Hello, my name is Jose Osorio. I'm an electrophysiologist at Grandview Medical Center in Birmingham, Alabama. It's my pleasure to talk to you today about our recent publication and presentation at the AF Symposium, Same-Day Discharge for Patients Undergoing AF Ablation, a prospective selection criteria with safety outcomes. Same-day discharge has several potential benefits for patients undergoing AF ablation, especially today during the COVID-19 pandemic, when we're trying to not only keep hospital utilization better, but also prevent patients from having to spend the night in the hospital. And also when you take into consideration the cost savings and patient comfort. It has been shown through other publications that most complications for our procedures will happen during or shortly after the conclusion of the ablation. Therefore, if you keep the patient in the hospital for observation for about 6-7 hours, most complications would have happened at that point, making the case that same-day discharge is safe. With that, there have been a few groups that show the feasibility of same-day discharge in low-risk patients undergoing AF ablation. These were typically patients undergoing ablation in the morning. There was no increase in complications, but in terms of the current publications, there's been no specific criteria to discuss what patients should undergo such process. And also same-day discharge was considered after the procedure. So the objectives of our study were to develop and test a criteria to systematically identify patients that could undergo same-day discharge. We want to do early identification of these patients, perhaps even in the clinic as you're evaluating, so that would allow you to change the order in which patients were going to have their procedure. So for example, a low-risk patient that could undergo same-day discharge, you would schedule them early in the morning. And with that, increase the likelihood that your program would increase same-day discharge. And then we wanted to compare the safety outcomes of these patients with a matched group of patients undergoing AF ablation that were not discharged home same day. We developed a criteria to identify low-risk patients. These were all paroxysmal AF patients undergoing ablation with radiofrequency energy with a target of pulmonary vein isolation only. All patients underwent ablation using a general anesthesia with propofol type of sedation. This is for two reasons. One, because it has been our protocol for many years to undergo, to perform AF ablation with general anesthesia, but also the anesthesia literature is very clear that with propofol, you have much better patient comfort post-procedure, less nausea, and an increased likelihood of same-day discharge for other operations. So the criteria we developed was patients had to be on stable anticoagulation without any complications or bleeding history, no history of systolic heart failure or pulmonary disease, essentially any comorbidity that would increase the likelihood of early complications and prolonged hospitalizations, no recent interventions, a BMI less than 35, and a low CHA2DS2 VAS score, typically 3 or less. After the ablation procedure, all patients had to undergo a 5 to 6 hours bed rest. At that point, there was intermittent ambulation in the prep and recovery area for the next hour or two. And after the intermittent ambulation, patients had a checklist that you can see that was going to be performed either by the electrophysiologist or by the nurse practitioner prior to discharge. So in this checklist, we asked the questions: did the procedure occur without any complications or perceived complications? Post-procedure confirmation by the electrophysiologist that this patient was suitable for same-day discharge. The purse string suture was removed. Stable hemodynamics, no evidence of any growing or respiratory complications, able to tolerate liquids and food, and able to ambulate with a reassessment showing no growing complications. After an overnight stay within 30 minutes from the hospital, in other words, we asked those that lived far away to spend the night in a hotel close to us. These patients were called the following morning at 9 a.m. by a nurse to assess for any complications and the potential need to come back to the hospital for reevaluation. These are our results. We then compared, as I said, the same-day discharge patients to a matched group of non-same-day discharged, 40 patients in each group, and all patients were called the next morning. We did not have a single patient that had the need to return to the hospital. We had similar efficacy at 3 months and similar safety for all patient groups, as you can see. Since we completed this protocol, this initial pilot, we have now progressed to started same-day discharge program for our paroxysmal, persistent AF ablation patients, and also for patients undergoing left atrial appendage closure. So about 70 to 80% of our patients today undergoing these procedures are going home same day without any safety events due to the early day discharge. All patients have a similar post-procedure protocol, observation in the prep and recovery area, and the phone call the following morning. So in conclusion, same-day discharge for AF ablation can have a significant economic impact for your institution. It may reduce exposure to COVID-19 patients. Importantly, during these times, it will improve bed utilization. Same-day discharge protocol such as this is going to preemptively identify patients that could be going home same day and will facilitate hospital and patient planning, increasing the utilization of such a program. A protocol like this, as we have shown, will help the safe initiation of a same-day discharge program at your institution. Thank you.